Ankylosing spondylitis is an inflammatory disorder of unknown cause that primarily affects the axial skeleton. Ankylosis basically means fusion of bones, and spondylitis means inflammation of the spine. Ankylosing spondylitis presents with bony fusion of the vertebrae along with sacroiliitis, that is, inflammation of sacroiliac joints as shown in this picture. Male to female ratio is 3:1. About 90% of people affected from ankylosing spondylitis are HLA-B27 positive, and among those inheriting HLA-B27, only 1 to 6% are affected from ankylosing spondylitis. Now let's move on to the clinical features of ankylosing spondylitis. There are many, so I have made a mnemonic for them. It is foursome backup, and the 4 stands for 4 of the clinical features start from S. Okay, so let's see what are they. Sacroiliitis. It is often the earliest manifestation of the ankylosing spondylitis. We have synovitis, squaring of vertebra, and syndesmophytes. Squaring of the vertebra is basically due to erosion and sclerosis of the anterior corners, and syndesmophytes are the areas of calcification around the annulus of vertebra. There is pain in the back that is relieved after exercise or movements. The patient may feel nocturnal pain and morning stiffness. Secondary osteoporosis of the vertebral bodies frequently occur, leading to an increased risk of vertebral fractures. There can be edema of the bone marrow, and we have enthesitis, that is inflammation of enthesis. Enthesis is the connective tissue between tendon and bone. So these are the features under the mnemonic foursome. Moving on. Anterior longitudinal ligament is a ligament that runs down the anterior surface of the spine. It traverses all of the vertebral bodies and intervertebral discs. Ossification of the anterior longitudinal ligament results in the typical bamboo spine in the X-ray. Aortic regurgitation can also occur. Ankylosis of costovertebral and costoesternal joints can occur that can result into restrictive lung disease. Kyphosis of the dorsal and cervical spine can be seen. Uveitis, the inflammation of the eye, and at last periostitis of the waist and prostatitis from P. And these are the features that fall under backup. So this is the mnemonic for the clinical features of ankylosing spondylitis. In lab findings, ESR and CRP are often but not always elevated. Rheumatoid factor, anticyclic citrullinated peptide, and antinuclear antibodies are largely absent unless caused by a coexistent disease. Now briefly on to the management. NSAIDs are the first line of pharmacologic therapy for ankylosing spondylitis. These agents reduce pain and tenderness and increase mobility in many patients with ankylosing spondylitis. TNF-alpha inhibitors like etanercept and infliximab can be given. Oral glucocorticoids can be useful for uveitis but not for spinal disease.